This is Kay Tillow. I'm with Kentuckians for Single Payer Healthcare. We are a nonprofit organization in Kentucky working to educate and advocate and organize to win a national single payer, not-for-profit healthcare system in our country so that absolutely everyone would be covered for all necessary care. We believe this is a vital project for the nation, that we are behind other nations that have been able to win universal care. And it's really important to us to mobilize our community and our state and our nation to press the Congress to pass legislation that would bring us an improved Medicare for all and cover everyone. So this is Single Payer Radio. It's a show that comes to you 3 times a week on Forward Radio. That's 106.5 FM, WFMP LP in Louisville, Kentucky. And we're proud to participate with the other people at forwardradio.org. You can reach Kentuckians for Single Payer Healthcare at kyhealthcare.org. That's our website, and on there is contact information. And we meet twice a month on the first and third Thursdays of every month at 5 p.m. And if you contact us through the website, we'd be glad to invite you to participate in those Zoom calls and help us to win this legislation that would bring healthcare to everyone. Our topic today is prior authorization and the mechanisms that are used by private for-profit healthcare to present barriers to care and to enhance the profits. So we're going to be examining that today. And I'm joined by 2 others who are activists within Kentuckians for Single Payer Healthcare.
My name is Charlie Casper, and I am a treasurer for Kentuckians for Single Payer Healthcare. I've been a member of the organization for probably 11 to 12 years now, and the topic is near and dear to me. I think it's one that is so past its time that we need to act on it immediately and get national health insurance for everyone under the single payer topic and Medicare for all. And some of the things we're going to talk about today are so foreign to what we want to establish in single payer healthcare. And that basically it's between the patient and the doctor. The insurance company does not get involved, and that's not happening today, and we have to do something about it. We talk about things like Medicare Advantage and some of the similar programs that insurance companies offer. And as Kay mentioned, the issue of denial of care seems to be something that's popping up more and more often. There are, in the past, there have been lawsuits against the insurance companies for denial of care that has not been right. And also things like having pre-authorization before you have a particular test or hospitalization that's required, and the delays are just incredibly long in some cases, and the denials is just something that's out there, and we have to pay attention to it. So those are some of the things we'll be discussing today.
I'm Paul Hoppe. I'm also a member of the Kentuckians for Single Payer Healthcare group. Normally, I'm kind of behind the scenes doing the technical aspects of the meetings and radio programs, but today I volunteered to participate in this discussion. And I agree with everything Charlie said. It's our slogan is there's patients, not profits. So our goal is to get profitization out of our healthcare system. Mainly, we've been focused recently on Medicare and Medicaid because the CMS, the Center for Medicare and Medicaid Services, are determined to completely privatize Social Security. So that's our short-term battle. Our long-term battle is, like Charlie said, single-payer health care for everyone, like every other country in the industrialized world, and many, many third world countries do provide for their citizens.
Because healthcare is a human right, and we need the legislation that will give us a healthcare system that makes it so. We have in this country the potential to have the best system in the world. We have, many, many fine physicians and hospitals and institutions and nurses, and yet we have a system that isn't working to give us what we need, and that is healthcare for everyone. I wanted to talk just a little bit about the thinking, what's at the bottom of why our system isn't working. And I think one way to explain it is that there is an insurance company way of thinking. Everybody agrees in our country that healthcare is too expensive. We know that, and we know that our healthcare costs about double per capita what the healthcare of other industrialized countries cost, and it costs too much. So we're all in agreement with that. Where the diverse positions come is that the insurance industry says that it costs too much because the people are getting too much care, and the doctors are prescribing too many tests. They're seeing people too much. They're hospitalizing people too much. There's too much care. And so we need mechanisms, according to the insurance industry, to curtail the care, to put barriers in front of people so they don't use it too much. And that will cut out unnecessary care, and that will cut back on the cost. It's a totally wrong diagnosis. We are not getting too much care. If you compare our nation to Japan or other countries, we see the doctor less often. We spend fewer days in the hospital. We are not overtreating to any extent. And as a matter of fact, we have the opposite problem, is that we have people going without care because they can't afford it, because of these barriers. So the insurance company says, let's put barriers to care so we can cut the cost. And so they came up with these mechanisms, copays, deductibles, got to pay out so much before your insurance kicks in. Prior authorization, they say, well, don't just let the doctor and the patient decide what procedure is needed. We need to run that through the bureaucrats in the insurance industry and let them deny that care or at least delay it. So that's the problem, is that the insurance industry, and unfortunately, they have won over many of the academics and mostly the legislative process, so that these mechanisms for denying care have been embedded into our healthcare system. We in the single payer movement say the opposite is what we need. We need to take away the barriers to care, get people in earlier, get preventive care, let people go easily and freely to see the physician. Let's catch the diseases and conditions in the early stages. Let's open up the doors to the care that people need, and we'll have a healthier nation. So we are at loggerheads with the insurance industry that says, you're getting too much care. We need mechanisms to curtail that. And the single payer movement, and indeed the country, that says we need to get the care to the people. We need to get all the care they need. We do not need bureaucrats second guessing physicians and patients as to what needs to be done. So that's one of the reasons we chose this topic. We're battling to win the hearts and minds to the ideology that understands and that promotes a more humane system. So one of the big problems is this prior authorization, which it's been a big topic in our community in Kentucky recently.
Yeah, I think there's a dirty little secret out there about prior authorizations that whenever a patient gets a letter or they phone their pharmacy to say what happened to my prescription the doctor sent in, they're told there's a prior authorization required, and they're just like at a loss. Well, what's going to happen? What can I do? Well, you can always protest that, and whenever you do take the trouble to protest it, they're normally prior authorizations are pushed through and you get your medication. But the problem is, I think it's what, Kay, 2% of the people actually protest. It's a very small number.
Right.
And so it takes work. You have to make phone calls. I mean, in my situation, that's happened to me a few times. And I call, of course, the pharmacy and ask what's going on. And they tell me, well, you need a prior authorization. I said, from who? My doctor, or she don't know, the insurance company. So I'm hesitant to call the insurance company. Obviously, you don't want to call a big corporation. You know what's going to happen immediately. You're going to get the runaround. You're going to sit on the phone. You're going to you're faced with this menu of choices, and you really don't know which one to push. So then you call your doctor, and the doctor says, "Well, yeah, I think I've written that up, or whatever." So sometimes you get excuses from your doctor, but eventually, if you're persistent, you can get it straightened out. But people who are sick or don't have anybody else to do that for them, what are they supposed to do? Just suffer. And and that's one of the great injustices of our healthcare system today.
Yeah, there's no question about that, and that we've heard about denial of care from many years ago, and I think, if I'm not mistaken, there was a segment on 2020 or I'm not sure what news show it was on that talked about that the employees of health insurance companies are basically taught that the first time around you deny the claim. And that is something that they anticipate. And it's amazing the number of people who don't call back because they've thought that it's just a waste of time to deny that the fact that they have denied the claim. And if you have to get your doctor involved, that's their time and their administrative staff to get involved. And it's just shown to be totally untenable. And back to what I said earlier, it should fall back on the patient and the doctor. For instance, with regular Medicare, you don't need prior authorization. And under a single payer system, there definitely would not be a requirement for prior authorization. It would just, again, be if the doctor sees it's something that has to happen, it'll happen. And we don't have to worry about getting a third party intervening to possibly deny it and put the patient in jeopardy.
Yeah, this prior authorization functions in the private employer-based system, and it functions within the private for-profit Medicare Advantage system, and it functions within the privatized Medicaid system. All of those have the prior authorization. The traditional Medicare, for the most part, almost exclusively, if the physician says it needs to be done, the patient and the physician can proceed with that. What were you going to say, Paul?
Well, I have forgotten what I was going to say, but in response to your last statement, everyone needs to be reminded that currently there's a plan by Medicare to be completely privatized by 2030. And so what Kay just said becomes invalid about traditional Medicare because it's really going to go away. So everyone will suffer. Today, the split is about 50-50, traditional Medicare versus Medicare Advantage and Medicaid and the other smaller programs that are administered. But it just seems inconceivable that our traditional Medicare would go away, but it is under attack. And so that's why we've been spending so much of our time trying to prevent that from happening.
Mhm. And we had, recent experience here with Medicare Advantage, and we would say Medicare Advantage is neither Medicare nor an advantage. It really is a private system where the money is paid through our public Medicare funds to an insurance company, which is then responsible for the care. And it sets up a mechanism where there's a contradiction between the financial wealth of the insurance company and the care of the patient. Because if they get paid something like $1,000 a month, the insurer does, and if they spend less than that on the patient, they get to keep the rest of the money in profits and overhead. So we shouldn't have someone whose interest is contradictory to the interest of the patient in the mechanism that can deny care. It's just not right. It's just an unethical, immoral situation that someone would profit from the denial of care. And that's what's built into the Medicare Advantage. So we've had this situation in Kentucky where people in Medicare Advantage, and some are in it because they didn't have any choice. Our retired teachers are in United Healthcare Medicare Advantage, and our retired state and county workers are in Humana Medicare Advantage. And those retirees didn't have a choice to go into traditional Medicare if they were to take advantage of their retirement health benefits. So now, recently, there's been a dispute between the Baptist health system and those Medicare Advantage companies. That means that people can't use the Baptist health physicians as being in network. And for some of them, they can't use the Baptist health hospitals as being in network, which is really important and can cause major upset. So this has had an impact on our community. And if there are people listening who have something that has happened to them as a result of this dispute, we'd love to hear from you. You can get in touch with us at kyhealthcare.org, and we'd be happy to hear about that. But prior authorization is one of the main ways, and it occurred to me, one of the ways in which it works so much against the patient is, for instance, if you've been hospitalized with a broken leg, and following the hospitalization, you go into a rehab center for physical therapy. It's at that point where many people on Medicare Advantage get a note from their insurance company that your days are limited, it's up in 3 days, we're not going to pay for rehab. And, I know of a person who was still not able to put weight on his broken leg and was told that his rehab time was up. Yes, he could file an appeal, but if you file an appeal, you have to pay for the days that you stay there while you're waiting for that appeal to be heard. If you lose that appeal, you're responsible for that money, which could be $300 or $400 a day. So the system is geared to not make it possible for the person to really actually challenge that. And that's a big problem. The person that I know still is limping to this day because of the failure to get the rehab that he needed before he was sent home. And that was because of the Medicare Advantage plan that he was on.
And in fact, there are a few lawsuits out there currently about that very thing, Kay, with respect to denial of care. and people in rehab facilities are being notified without any prior notification that their stay in the physical therapy home is not going to be covered anymore. So then they are right back to what you said. They have to go and protest and file an appeal. And in the meantime, they have to pay from the day that insurance company cuts them off. The other thing that's interesting is in a couple of these lawsuits, the plaintiff's attorneys have filed that the insurance companies are using artificial intelligence with certain algorithms to deny care to people that need it. And that's just incredible. How do you go back on an AI sponsored program that has these algorithms built into it that will deny care to certain people for whatever the reason? And I don't know where in the world they came up with that. And I mean, some people would say, actually, that's not any different from a live body answering the phone and denying care. It's the same end result. But to have it out there automatically in advance, knowing that they're going to deny the care of people that are already in a rehab facility, it's really frightening to me when you think about it. And what else could they come up with?
I don't know. That's, part of what the lawsuits are over. I think it's some company named NavaHealth that provides artificial intelligence. But goodness, that tells us that there's no thinking professional physician who is there making the decision and analyzing and evaluating your particular condition and what's happening with you. It's a mechanism that's, an algorithm that is kicking you out. And of course, that's what the lawsuits are about. I think there's one against Humana, Medicare Advantage, and one against United Healthcare, and maybe more over the artificial intelligence. But, long before they had that, you're right, they have utilization review doctors and nurses who are paid by the company. They're not going to be making decisions that the company doesn't agree with, since their financial interest is in reducing the amount of care that they have to pay for. Those doctors and nurses are put under the stress of making the decision in favor of the company's financial interest. That's why it's just wrong that the private insurance industry dominates our healthcare system and is doing this to us and subjecting so many millions of people to decisions that really compromise their health and their lives.
And I kind of get amused at thinking about the algorithm of the AI. I think of a robot, of course, answering the phone and saying, "We're very sorry that your stay in the rehab facility is going to be denied." And you wonder if they're going to issue an apology. It's got to be part of the algorithm process, right?
I don't know.
You go ahead and tell that patient you're very sorry from the bottom of my heart. And even though I'm a robot denying that, and I start to chuckle, it's not funny, but how in the world do you get around that? It's amazing to me, but it happens, obviously.
It is, it reminds me of the algorithm that, who is it in Indianapolis? I think it's Anthem, had an algorithm that went back and found this was before the Affordable Care Act, it found the people who had breast cancer And then the algorithm kicked them out, so they didn't get offered renewals on their insurance, so they wouldn't have to cover these people. I remember that so well, in spite of the fact that, you know, Anthem on its door used to have that pink ribbon saying, you know, we love women who've had breast cancer. We just kick them off of our insurance plans because we don't want to pay for their care. And it's more algorithms that are doing it. But, you know, it's not just the prior authorization. They also have formularies for drugs, and they keep out people who have certain need for certain drugs. For instance, one of the ways, after they were told, the insurance industry was told you can't discriminate for pre-existing conditions, they still managed to find the ways. They would put the drugs for things like MS and other diseases that are debilitating on a different tier, so that the people wouldn't purchase that plan because the drug that they needed wasn't there. So they have 1,000,001 ways to get around the regulations that have, with very little success, tried to impose a fairness upon the insurance industry when it comes to treating people. And CMS, which as Paul talked about, the Center for Medicare and Medicaid Services, has not been successful at all in curtailing these practices that are so harmful. They audit very few of the records. They're just now, after decades, looking into the advertising practices of Medicare Advantage, but they have no way, they don't have the staff or the ability to look at every ad that's done. You know, these brokers who sell Medicare Advantage, they get more money if they sell a Medicare Advantage plan than if they sell a supplementary plan to traditional Medicare. Well, what do you think they're going to sell? You think they're going to make sure that the patient gets the right plan, or they're going to be pushing the one that they make the money on?
So contrast that with what we're touting in a single payer system where there's none of that. You don't have to argue and fight with the insurance companies for Medicare Advantage for prior authorization or denial of care. It's just automatic between you and your doctor. If your doctor thinks it's necessary, you've got it. And that's one of the beauties of single payer. It continues on just in that fashion, and everyone's covered. Nobody has to fight to appeal an unfair ruling on the part of the insurance company.
Mm-hmm. You know, how many people do we have who stay in a job that they hate because it provides health insurance? And they are not able to venture out to look for something better, or to, you know, work in another way as an artist or something else, because the insurance ties them to a company, and their freedom is really lost. And think how free we would be if we had health insurance coverage cradle to grave for all of us, for our families, our neighbors, everyone. The kind of freedom that that would allow to pursue the employment, the career, the opportunities that are before you, if we didn't have to worry about getting a job that had really good health insurance. And for those who say they don't want the government running the health insurance, we don't have any freedom when we have a private insurance industry that runs a system and has the ability to deny us care.
Yeah, the point you just mentioned about somebody staying in a job they absolutely hate, I mean, that takes a tremendous measure on their personal health and how much health care they actually end up needing because of that stress from being in that job that they can't stand. And So those are all costs that hidden costs of a poor healthcare delivery system like we have that people don't really think about. And I guess, and then there's another thing. I mean, I hear this quite a bit about how terrible our healthcare system is, and I just want people to realize that the United States has the best healthcare in the world. What's terrible in this country is the accessibility of that healthcare, and that's what we're trying to rectify.
And back to the job situation again, Paul. Imagine having your health insurance with you in your back pocket. Imagine that you're disgruntled with the job, you don't see any place for advancement, and you can walk down the street to the next opportunity, and your insurance is with you. You're already covered under a single payer system, and you don't have to worry about delays, 90 days until the insurance kicks in because of the insurance company. You've got it. It's there. You signed up for it, and it's your insurance. And
Exactly.
that's what single payer offers.
I've read so many accounts of expatriates that moved to Europe that bring that up all the time. Exactly how you said it. They carry their insurance card in their pocket wherever they go. It goes with them, and they tell of how it freed them to either excel in their careers by moving from job to job and not having to worry about insurance, and also even if they want to change careers, they still have their health insurance with them. It just seems like such a much better deal than we have in this country right now.
Yes, indeed. And, if you look at, there are lots more problems that relate to the system other than the prior authorization and the step on pharmaceuticals. But if we look at the rural hospitals in our state, in Kentucky and in other states, they are struggling. They are struggling to survive because the payment mechanisms aren't set up to assure their survival. And we need to keep an infrastructure with a healthcare network so that all of the people of our country have access to it. And it's not working. So we see one by one, rural hospitals are closing down. They can't maintain the services. They can't keep labor and delivery. They can't keep maternity services. They can't keep the ambulance services. They can't keep the emergency room. And many are closing down, are being bought up by private equity and then sold in another way or transformed in another way. So we don't have a system that sustains the infrastructure so that everybody can have access to care. That would be solved with a national single payer system that puts hospitals on a global budget and provides each hospital with the amount of money that is needed to sustain the care in their area of the country. So we need to do this for that reason as well, so that we can keep hospitals running and access available for everybody in the country.
I think right now is a good time to remind everybody and inform those who don't know this of the overhead that's involved with Medicare, traditional Medicare, for instance, in providing what most people perceive as very good care in healthcare delivery that operates on a 2% overhead as compared to the privatized side of Medicare, which is Medicare Advantage, Medicaid, where those private companies are operating on overheads of 15% typically, I guess on the average. Some end up getting even more than that. And that's all profit that could be going to administering healthcare.
That's true. And that's really important. Why should we have private companies that take 15 to 20% of the dollars for care and use that for administration and profit when we could put that money into healthcare and make healthcare better for everyone? We could cover those things that aren't covered. We need in this country to have long-term care covered because many people lose the wealth of a lifetime by going into a nursing home and are unable to pass anything on to their children because it's eaten up in Medicaid taking the money. And we don't have a system that would assure that people don't lose their money in that kind of thing. We don't have long-term care covered. We don't have a lot of mental health covered. We don't have hearing aids and eyeglasses and dental work covered in most of the plans, as though those weren't parts of the body that deserve to have any care. So, we in Kentucky, we have lots and lots and lots of people who can't get the dental care they need because of the cost. That needs to be covered, and that indeed is covered under the legislation that would set up a national single-payer healthcare system.
That's what you talked about is commonly referred to as above the neck. And
Oh, really?
think about it, your ears, your teeth, your eyes, and plus your brain. But there's a little more being done these days in terms of mental health, but not nearly enough. But yeah,
No.
we need healthcare that includes the whole body, including above the neck for everybody.
Yes, our above the neck and our feet and everything in between.
And one thing that I've always enjoyed mentioning is when you have a single payer system that covers everyone, the hope is that you bring Congress into the same system so that they don't have their own prized blue ribbon insurance that they have now. They're part of the same system that we're all under.
Mhm.
That would ensure that there's absolutely no problem getting the plan funded. And
Right.
that's why, to me, it makes abundant sense for us to have a single payer system everywhere and that everybody's under the same plan.
That's
And
right.
makes all the sense. House Bill 676, which was introduced a couple of decades ago, I believe, had that very provision in there that they wanted to have coverage for everybody, including government officials and everyone. That would ensure that you have a good program. No
That's
question about
right.
it.
That's important. It's important that we don't have a two-tiered system, because if everybody's in it, Charlie's right. They help us to keep it strong and to keep it funded. And if it's means tested, in other words, like Medicaid is now, and I know Medicaid, it's good that we have it instead of having nothing, but it's not good. It is not good to have a lower level of care, a level of care where the doctors who serve that population are paid less for serving them. That makes it hard for people to get specialists, hard to get in. It changes the way they are treated within the system. It's not right to have a two-tiered system. And of course, the Medicaid isn't sufficient, the payment, to sustain practices and hospitals where those are the only patients they have. If they don't have private pay patients, they have a difficult time in sustaining themselves. So we need everybody in, nobody out in one system, and the politicians as well, and then they'll help us to keep it well funded and to make sure that it's good. And it doesn't cost more money. I mean, that's the mistake. People say, oh, you can't afford single payer healthcare. We can't afford not to go to single payer healthcare. The system that we have now costs double per capita what the single payer systems in other countries cost. We can't afford to keep on this track where we're financing a bloated insurance company and private equity and venture capital through our healthcare system. We need to use that money to fund the care, not the venture capitalists.
Well, I couldn't agree more, Kay. But it's getting back to prior authorization. I just read where the CMS has put into effect a new rule on prior authorization that just in January of this year, and they have lots of criteria for how these insurance companies are supposed to play by this set of rules that they have, and they're not stringent, and they're basically all tied to electronic systems that they have to adhere to. In one case, I saw that the provider only has to make one transaction per year in order to stay up to date on that particular ruling. It's just, if you read through it, it's just more nonsense coming out of CMS.
I think you're right, Paul, and that, I think CMS made this move only because there's been a considerable protest movement out there demanding that something be done about the overpayments.
Yeah, and it only takes effect starting in 2027, I believe.
Oh, well.
And again,
For years.
this rule excludes drugs. That's still under the old system, whatever that is. This is only for medical items and services.
But the CMS is so bad at, in fact, it's not possible to monitor every transaction that takes place within 1,000 insurance companies and millions of patients. And they audit only a tiny proportion of those. So nobody's on top of or able to scrutinize these practices. And so if they get away with only, 90% instead of 100% of the cheating, they're still going to be able to do it. They do something called upcoding. They take a particular patient, and because Medicare will pay them more money if the patient is sicker, they make the patient look sicker than they are, so they can increase the amount of money they get per month for a Medicare patient from $1,000 to as high as $30,000 a month by saying, well, the person said she was dizzy, and then so that means this, and to increase the intensity of the coding that would say that our risk is greater, even though these private Medicare Advantage companies have a healthier patient population than the ones in traditional Medicare. And even with that, they spend less on care and they cost the public more per patient. So why do we have Medicare Advantage at all? If it costs us more and it gives us less care, it's just a drain on the system. There's no reason to have it.
I think it's also important to emphasize to those listeners that I'll only speak for myself, but I'm a capitalist. I believe in a person being able to make a good living, have a good job, make as much money as they can. But the only place that I disagree about having capitalism is in our healthcare. We shouldn't have for-profit healthcare. And that's what this country is hung up on, and that's what's gotten us into this mess that we're in today. Everybody complains about our healthcare system, but few people try to understand why it is the way it is. And that's what we work to educate people on this aspect, and hopefully get everybody involved in demanding that we get treated as at least as well as other people in the industrialized world when it comes to healthcare.
I agree with that, Paul. We do have majority support for our position. The insurance industry says, nobody wants the government to control your health care. Well, we don't want the government to control it. We want the government to publicly finance it so that patients and physicians and the people who have the professional background can make the decisions about healthcare. We want that to be freely available to people, and it isn't now. We're spending more and we're getting less. We're not getting the healthcare we need. I think we have up to 40% of our people that go without or delay care that they need because of the cost. Now that's outrageous, and that includes people who have insurance plans. because our insurance plans have these deductibles and these copays and narrow networks and all kinds of barriers written into them that keep people from getting the care. We even have 100 million people with medical debt. You know, that doesn't happen in other countries. People don't go into debt for their medical care, but here we do. We have 100 million people who have medical debt. That's close to a third of the population that is suffering economic hardship as a result of having to pay for care. And that's how many years since we passed the Affordable Care Act, which was supposed to reform the healthcare system and make it possible for everyone to get care. And it's not working. And we need the further reform that would actually bring about everybody in, nobody out, healthcare for all. And that's a national single payer, improved Medicare for all plan.
I want to go back and correct something I said about the new CMS final rule on prior authorization. It takes effect in 2026, not 2027.
Okay.
And again, it's very strict. They have 7 days to respond to a standard request. So I guess in the meantime, the patient, while they're waiting for their acknowledgement from the insurance company that they can't get the treatment that they want, I guess they just suffer, right? To me, that's what it says. I don't know how else to interpret that.
Well, I think that's why people are seeing the prior authorization cracking down when they're in rehab, because those companies know that you're under the pressure to make considerable prior payments if you appeal and don't win. And that increases the pressure on people to get out and not to go through with the full appeals and, you know, of the denials. Plus, you know, people have to do this when they're sick. You know, it's not like you can handle it when you're in great shape. You've got a broken leg or a broken something and you have pain and distress. And that's the time when you have to deal with the stress of a healthcare system that doesn't work for us. It should be automatic. I remember when my mother used to have to choose a drug plan, and she was an intelligent woman and a school teacher, and she would say to me, "Kay, I just don't know which one is the right one." And I said, "Mom, there's no way to know, because the drug companies have a right to change the formulary mid-year. So even if you do due diligence and check off all your drugs against the formulary, it can change on you in the middle of the year. It's not like we have the ability to foretell what's going to happen." I know I think it was, I can't remember who it was, who said that, well, if you're going to choose the right plan, you first have to decide what diseases and conditions you're going to have in the next year. And then you have to decide what doctors and hospitals you will need for that. And then you have to decide whether or not they're in the network. And if there's no plan that reflects that, you have to go back and choose different diseases and conditions. Which is
just amazing.
That's, you know, the system, it's not one where it's clear how you can know in advance what to choose, but that stress is on everybody, and particularly our seniors. You know, every year they're supposed to do a new evaluation of what's the best plan. The reality is, if you choose a private plan, Medicare Advantage, you may come out better if you don't get sick, because the payments monthly are less. So if you don't get sick, you could come out better. If you get sick, you will definitely come out worse, because the plans are geared to escalate the costs when you are sick. And then the prior authorization and the narrow networks and the copays and deductibles will kick in to make you miserable. And then on top of that, once you figure out that this Medicare Advantage isn't working for me, if you want to go back to traditional Medicare, you no longer are protected against discrimination for pre-existing conditions. Now that you're sick, you may not be able to purchase a supplementary plan or a Medigap plan to go along with your traditional Medicare. It's a terrible thing. There are recently articles about people are trapped in Medicare Advantage because they've now lost the protection. You know, we introduced a bill in Kentucky a few years ago with Tom Birch that would end that ability to discriminate on the basis of pre-existing conditions in the purchase of Medigap plans. It didn't pass. The insurance industry was in there working against it, but that still exists. We still have people who suffer from pre-existing conditions, keeping them from the health coverage they need.
Well, and the other, go ahead, Paul, I'm sorry.
Charlie, I was just going to tell the story about my mother-in-law. I know she won't mind, but she's 87 now, and I guess I've been advising her on lots of different things, including healthcare, and since she turned 65, and so she chose Medicare Advantage because of the obvious reasons, very low premiums, and now it's evolved since then, since she turned 65, into the freebies that they offer and entice people to sign up with. But I've been telling her for years that people who have Medicare Advantage sign up normally because they can't afford anything better currently. And secondly, they don't really realize always what a gamble they're taking. And that's what it is. You're gambling on your health, because if you get really, really sick, then you're going to find yourself in a mess. As lots of people, like Kay just said, they find themselves stuck in Medicare Advantage. She's been very fortunate. She took the gamble. She's not had any serious health issues. And so now, 22 years later, she's delighted still. She still loves her Medicare Advantage. But so, yeah, lots of people skate by and they don't get in trouble. But that's having to take that gamble on your health care is, to me, is never going to be a good bet. So that's why I think we need to change the system. And that's why we think single payer health care for everybody is the answer.
Yeah, we do away with Medicare Advantage, then we have to fix it with an improved Medicare for all, because we don't want a situation where the people who are paying less have to pay more. We want it fixed for all of us. And that's why it's important for everyone to become involved in this. You know, in a democracy, those things that are good for the country and have majority support, those ought to be passed into law. We've had majority support for national single payer healthcare for decades, and we haven't been able to do it yet. And we have to have more people involved in insisting that the Congress do what is right for the nation and enact a national single payer healthcare system to pay attention to the healthcare needs and the quality of life and to social justice, rather than to the financial interests of the insurance industry and the venture capitalists who are gotten involved in our healthcare system and are dominating it. We have to work on it until we make it happen. I don't want to hear people say, hey, we can't do it right now, so let's do something else. No, there's nothing short of a national single payer healthcare system that will fix it for all of us. And we don't want to leave anybody out. Everybody in, nobody out. That's been the tradition of Physicians for a National Health Program for many decades. And we can't just fix it for a few. You know, there's no way we're going to be able to patchwork this and, you know, spend 2 more decades trying to get Medicaid expanded to the states that didn't expand it. In this country, we lost over 1 million people to COVID. And, you know, the figures are showing that 300,000 of those would not have been lost had we had a healthcare system that was able to handle that pandemic. So we're losing lives, and we're losing people that we need, and we're losing what makes a great nation, and we have to fix it. And we invite everybody to come and join us in working to make it better. We meet the first and third Thursdays of each month, and you can get in touch with us through our website, which is kyhealthcare.org. And we'd be glad to have you join in our Zoom meetings. And we'd like to offer to any organization in Kentucky, we do presentations on single-payer healthcare, on the privatization of Medicare. We have some films. We'd love to come and talk with your organization. We'll present a program with an expert free of charge, and we'd love to come. Just get in touch with us. We thank you for joining with us on Single Payer Radio. We come to you every week, and this is Paul Hoppe and Charlie Casper and Kay Tillow with Kentuckians for Single Payer Healthcare. Thank you for listening.